it includes biological factors, psychological factors, and also social factors that are not only determinants of disease, but also can help with formulating a treatment plan which incorporates all three areas. So as an example, इसमें you have the biological component, you have the psychological component, and you have the social component. And that you have predisposing factors, perpetuating factors, and also precipitating factors, and there are certain protective factors. Predisposing factors may, a good example is genetic, past psychiatric history, medications, drugs, alcohol. Psychological factors may that predispose a certain person to certain illnesses is obviously पहले ज़माने में it used to be a type A personality, people always being on time, always being high driven. That's not been really shown to have much correlation with heart disease nowadays, but for a while type A personality was factored into predicting heart disease later on, or ischemic heart disease or cardiovascular disease. Obviously, self-esteem aa jata hai, body image, what do you think about your illness? Those are all predisposing factors. And then you have social factors, including socio-economic status, support, etc. In precipitating factors, again, medication, they all kind of interact. So medication, non-compliance, medication side effects. Obviously, drugs and alcohol can be both precipitating or predisposing factors. And then precipitating factors could be stage of life, like losing a job, loss, grief, loss of a family member, loss of a spouse, loss of a parent. And in social factors of obviously work aa jata hai, which could loss of work could be a precipitating factor for an illness, not only psychiatric, but also medical. And then you have finances, relationships. Perpetuating factors are kind of all related. They can all perpetuate the illness if you don't address these factors. And then there's certain protective factors. Obviously, if you're in good physical health, you don't have a history of any substance use, that's protective. If you're able to engage with your care provider, you have a good relationship with your physician, with your psychiatrist, whoever that you're seeing, obviously that's going to have a positive impact on your illness. Insight, as we know it, is knowing that A, there's something wrong with me, and B, I need to do something about it. If obviously insight hai कि जी, I'm ill and I need to get help, that helps. And then medication adherence would definitely be a strong factor. I mean, there's no sense in you prescribing a beta blocker to someone who's had an MI if he or she is not going to take it. And then coping strategies such as, again, trying to modify some risk factors such as reducing smoking, getting some exercise. That also helps. Okay, so this is again, it's a nice table to have. Anytime that you're seeing a patient, you can just circle the issues. We'll just go over a case and come up with इनके क्या-क्या risk factors, इनके क्या-क्या formulation हो सकता है in terms of the biopsychosocial model. So Mr. A is a 35-year-old single male who presents with an acute myocardial infarction. His past medical history is significant for aortic stenosis, increased cholesterol, and smoking. He remains non-compliant with medications. He smokes a pack a day. Family history is significant for cardiovascular disease and diabetes. He lives alone and his family is in a foreign country. Because of COVID, he may lose his job as a hotel manager, so that's obviously a stressor for him. He's always been aware that's a predisposing factor and pessimistic in his thinking. He was recently prescribed an SSRI for clinical depression, and again, that may be a predisposing factor. So going back to this framework, under predisposing factor, we can clearly circle off genetic, family history here. Illness, he's got a psychiatric illness in terms of depression, and we do know that depression increases the risk of cardiovascular events, including MI, recurrent MI, and death. SSRIs, by the way, are protective. Physical illness we have as a predisposing factor, the aortic stenosis. So let's not forget about that. That can obviously cause hypertrophy, and you know better than me that it can cause obviously ischemia and angina and MI. He also, you can also circle off medication. वो actually medication में precipitating में आ जाएगा because he's been non-adherent to his medications. So we don't have any contributory medication that's causing his MI, but obviously he was non-compliant with his medication, then that is very well a precipitating factor. He does smoke, so that's a predisposing factor. Under psychological, in terms of predisposing, his personality, he's pessimistic, he worries a whole lot, and obviously chronic stress will have a negative impact on your physical health and on your mental health. Social predisposing factor, he lives alone, so he doesn't really have any social supports. We know his family's in a foreign country. He may very well be in a foreign country and not speak the language very well and be isolated. Given the same case history, we have the precipitating factors, like I talked about, the medication non-compliance, drugs and alcohol. He does smoke a pack a day. Psychological may, he is facing a loss of his job, which may be because of the current COVID situation. Many people are not traveling, and obviously hotels are losing business and they may be downsizing. Under social factors, obviously if he loses his job, he's going to suffer financially, and so in terms of formulating a treatment plan for this man, it's just not prescribing medications for his post-MI care. You're obviously going to do what's needed, put him on an aspirin regimen, put him on a antiplatelet regimen per guidelines. You're going to put him on a beta blocker, you're going to put him on an ACE inhibitor, etc., etc. You're going to put him on a high-dose statin. But those are, it's no good if he's not going to take it. So there are other things that you really need to do. You need to engage with this patient. You need to enhance his protective factors in terms of engaging with this patient. You need to educate this patient about his illness. Hopefully, if there is any family or friend, then engage with that family member or a friend of his that can help with his medication compliance. You need to modify risk factors that you can modify, such as sedentary living, smoking, obesity. So those are things that you can really help. So it's just not, the whole idea behind the biopsychosocial model is that you're not just prescribing medications and that's it. You need to address everything in this patient's life. अब आप नौकरी तो इनको दिला नहीं सकते हैं, ठीक है? But obviously, if he may lose a job, then you may refer him to social services to help with financial assistance if that country is able to do that, or some vocational therapy that he may be able to look at or find another job. So that's your biopsychosocial model in a nutshell. All right, talking about PTSD. It's a psychiatric disorder, obviously. It occurs in people who've either witnessed a traumatic event where there would be necessary loss of life or limb, or they've heard about it happening to a family member. So yet a traumatic event can be anything like a natural disaster, a serious accident, a terrorist attack, war, combat, sexual assault, personal assault. A traumatic event is not failing in your neuroscience module. Okay? That would not classify as a traumatic event enough for PTSD. If you have psychiatric disturbances after you fail your neuroscience module, most likely that diagnosis would be adjustment disorder with mixed features of emotion and conduct, which comes in as a differential. In the past, PTSD has been known by various names, including shell shock during World War I, and then combat fatigue after World War II. The prevalence of PTSD is around 8% in the general population. It's higher in the military population. Given the fact that it's only 8%, which is remarkable that people are very resilient to trauma. I see so many patients from Afghanistan and Balochistan who have been involved in bomb blasts and whatever traumatic event, and very few of them actually meet criteria for PTSD. Yes, they do meet criteria for maybe another psychiatric illness, such as anxiety, depression, and ज़्यादातर उसके साथ ही आते हैं. When we screen for PTSD symptoms, it's just a small minority that has PTSD symptom, and I'm sure the same would apply for people living in Karachi. We're just so immune. We've got habituated by trauma every day, including having a mobile stolen at gunpoint and etc., 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 that we've just kind of immune and habituated to traumatic event. Majority of people in the population have had experience of a traumatic event, whether it would be at a personal level, at a population level, or they have heard of someone being involved in a traumatic event. However, like I said, the prevalence of PTSD is around 8%. It's 2 times more common in women. It's also more common in women who are not don't have a job, and also who have a lower level of education. All right, as I said, a diagnosis of PTSD requires an exposure to an upsetting traumatic event where it may involve loss of limb or life. PTSD can develop actually if you're undergoing surgery and the anesthetist hasn't given you enough muscle relaxant and anesthetic medication, and you wake up in the middle of the surgery. It's been documented. It could also occur in the individual learning about a family member being involved in a traumatic event. By the way, it also can be diagnosed in people who are reporters who have to report traumatic events. It's very common in people who work in the emergency room, who drive ambulances, who are what we call as first responders, namely the police, fire, ambulance drivers. Now, if you watch films of trauma every day, that is not being subjected to an upsetting traumatic event, even though you might be upset. And if you have any symptoms related to that, it would not fall under PTSD. Journalists covering violent events can develop PTSD. Last but not least, actually PTSD can develop in people who inflict trauma to other people, who torture other people, so they can end up developing PTSD. Now, treating them becomes a whole ethical issue, which is not the discussion for this lecture today. All right. Symptoms. There are 4 symptoms of PTSD. One is intrusive thoughts, repeated involuntary recollections, distressing deep dreams, and flashbacks. Flashbacks can be so realistic that you feel transported back in time, reliving that trauma. I remember I had a patient when I was in training in the US. He had served in the Vietnam War and obviously had seen a lot of trauma. Anytime a helicopter flew overhead, he would feel transported back on the battlefield. During one such event, he actually felt that he was actually being attacked, and he ended up stabbing himself in the abdomen. Luckily, he survived that incident. The other classic symptom is avoiding reminders. So you're going to avoid reminders. Suppose you've been incarcerated, aapko jail mein rakha gaya hai 8 saal tak, which is now I'm seeing that with a lot of my Afghani patients. So you're going to avoid driving past the central jail here, which is just down the road. So you're going to avoid people, places, and activities that remind you of the trauma. The third symptom is negative thoughts, where you feel you're not good, I am bad, I cannot trust anybody, You have ongoing guilt, shame, less interest in activities. And the other thing is that you feel that your time is going to be short. You also feel detached and estranged from strangers. And the other fourth symptom is arousal and reactive symptoms, and that includes being irritable, being angry. And a lot of patients do present with being irritable and angry, but they don't have other symptoms of PTSD like nightmares, flashbacks, avoidance, intrusive recollections. One of the things I ask patients who have a history of being trauma is कि आप बहुत जल्दी से चौंक तो नहीं जाते, meaning easily startled if someone comes behind you and says boom. So, and obviously they have problems sleeping and concentrating. Okay, so these are actually symptoms of PTSD. Now I'm going to show you a small video about PTSD, so just bear with me.
Post-traumatic stress disorder, also called PTSD, happens when some memory of a past traumatic event, like war or sexual assault, causes recurrent mental and physical distress. Now, the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition, or the DSM-5, categorizes PTSD as a trauma and stressor-related disorder. That happens when symptoms of an acute stress response persist for over a month. The main symptoms are psychological ones. For example, someone might re-experience their trauma through nightmares, flashbacks, and intrusive thoughts. But these can lead to behavioral changes as well. Somebody might start to avoid environments and situations that remind them of their trauma and feel a sense of hypervigilance, where they're constantly on guard, or hyperarousal, where they have this exaggerated startle response to the smallest of triggers. Not surprisingly, all these thoughts and behaviors can lead to trouble sleeping and general irritability, which can lead to angry outbursts. Interestingly, this pattern is different for young children, who are less likely to show distress, but instead they might use play to express their memories, sometimes acting out scenes that trouble them. Whether or not someone develops PTSD in response to trauma is determined by a number of different factors. For example, it's clear that interpersonal trauma, like rape or violent muggings, are more likely to result in PTSD than accidents or environmental disasters. In addition, people that go through extreme trauma as children are more likely to develop PTSD in response to other traumas faced in their adult life. Having said that, if someone manages to develop effective coping strategies for trauma, including having a social support network, then that can help with future traumas as well. As far as causes go, there are some clues about biological factors related to the development of PTSD. For example, people with dysfunctions of the hypothalamic pituitary adrenal axis, deficits in the arousal and sleep regulating systems in the brain, and problems with the endogenous opioid system, which helps with pain.
Presentation को stop sharing कर दे सर.
Yeah, hold on. Video aa rahi hai?
Post-traumatic stress disorder, also called PTSD, happens when some memory of a past traumatic event, like war or sexual assault, causes recurrent mental and physical distress. Now, the Diagnostic and Statistical Manual for Mental Disorders, the 5th edition, or the DSM-5, categorizes PTSD as a trauma and stressor-related disorder. That happens when symptoms of an acute stress response persist for over a month. The main symptoms are psychological ones. For example, someone might re-experience their trauma through nightmares, flashbacks, and intrusive thoughts. But these can lead to behavioral changes as well. Somebody might start to avoid environments and situations that remind them of their trauma and feel a sense of hypervigilance, where they're constantly on guard, or hyperarousal, where they have this exaggerated startle response to the smallest of triggers. Not surprisingly, all these thoughts and behaviors can lead to trouble sleeping and general irritability, which can lead to angry outbursts. Interestingly, this pattern is different for young children, who are less likely to show distress, but instead they might use play to express their memories, sometimes acting out scenes that trouble them. Whether or not someone develops PTSD in response to trauma is determined by a number of different factors. For example, it's clear that interpersonal trauma, like rape or violent muggings, are more likely to result in PTSD than accidents or environmental disasters. In addition, people that go through extreme trauma as children are more likely to develop PTSD in response to other traumas faced in their adult life. Having said that, if someone manages to develop effective coping strategies for trauma, including having a social support network, then that can help with future traumas as well. As far as causes go, there are some clues about biological factors related to the development of PTSD. For example, people with dysfunctions of the hypothalamic pituitary adrenal axis, deficits in the arousal and sleep regulating systems in the brain, and problems with the endogenous opioid system, which helps with pain control, have all been shown to be at higher risk for developing PTSD. PTSD has also been linked to having a family history of mood disorders or anxiety disorders. The precise mechanism, though, that ties all these relationships together has yet to be worked out. Treatment for PTSD can be kind of complicated, since people with the disorder are often reluctant to engage with the trauma in any way, in their thoughts, their emotions, or in their conversations, which can make treatment really hard. Research has shown that exposure therapy, which slowly exposes individuals to situations that cue recall of the trauma, can be very effective. Group therapy is also a popular choice for people with PTSD, because it provides survivors with a safe place to relive their trauma in a supportive environment. In terms of medications, antidepressants, in particular selective serotonin reuptake inhibitors, or SSRIs, can help to reduce depressive symptoms that often accompany PTSD, and can help minimize flashbacks and nightmares. Anti-anxiety medications can help decrease the heightened physiological arousal often seen in people with PTSD. And finally, sleep aids can be helpful because lack of sleep and restlessness is such a serious problem with PTSD. In addition to this, a lot of people with PTSD self-medicate with alcohol and other substances, which can actually worsen their symptoms and their overall health. So, an important treatment consideration for both therapy and medications is to help alleviate their symptoms while also safely managing substance abuse issues. So, as a quick recap, PTSD usually happens after a violent interpersonal trauma and involves recurring thoughts that persist for over a month, and can be managed with effective